is starting to gain more and more attention in terms of there have been study after study using like large databases looking at hepatitis C prevalence among people of reproductive age, and in particular, people presenting for delivery. And what we're seeing is that the rates are increasing at a staggering rate. It's really becoming a huge issue. And it's unfortunate because we don't have interventions to treat people who are pregnant. So the natural consequence of that is increased perinatal infections. So there also have been more and more research that's come out recently about the risk of perinatal transmission. It used to be thought to be a 5 to 6%. We're thinking now that it might actually be higher, like 7 to 8%. And so my question was really like, what's happening to these children? I'm an adult infectious disease doctor, an internal medicine doctor. So I have seen the effects of cirrhosis, and it is serious. And what we know from the natural history studies of pediatric hepatitis C is that for those who don't clear the infection spontaneously, about a third will develop cirrhosis, which is irreparable scarring of the liver, by the third decade of life. And so that really made me think that this is a population that needs to be thought about, even as not a pediatrician, but as an adult doctor. But I do work really closely with med peds doctors, like Dr. Epstein, who was one of my co-authors, who was able to help me a lot in terms of understanding the context of pediatric hepatitis C. Yeah, well, I just have to say that direct-acting antivirals are such a breath of fresh air in terms of having something that is so curative, especially coming from an infectious disease background and specifically HIV, where we do not have a cure. So I thought, as I learned about the effectiveness of these medications, I thought about really how we could get these out to people. And I started talking to my friends who were pediatricians, and they weren't really screening kids for hepatitis C. And what I ended up seeing in a lot of either statewide or single center studies is that the majority of children who are exposed to hepatitis C perinatally actually don't access the screening that's recommended. So, way before we talk about the care cascade, and that's kind of like every specific step that someone needs to go through to reach a health outcome. It comes from the HIV literature, but it's really come about in hepatitis C, and people talk about it a lot because it can be somewhat complicated, and people have an opportunity to fall off at every step. So what I saw before me was that kids are falling off the cascade before they can even reach treatment. They're falling off before they're diagnosed. Having a background in epidemiology, I was thinking, where are these kids? They have to be somewhere. And what can we do to link them up with this treatment? Because it is happening in some instances, but it's not being rolled out or being paid attention to in the same way that we're rolling out, say, hepatitis C direct-acting antivirals for like the baby boomer generation. We did an amazing job with that. Why aren't we focusing the same attention on this next generation? So I wanted to answer, I'm very interested in decision analysis and simulation modeling, using these methodologies to really project long-term health and economic outcomes, because I think that those are two really important pieces of impacting policy and raising awareness. And so that was kind of why I started thinking about, what if we could show the long-term impacts of intervening early and treating these kids when they become eligible. A lot of times we have to kind of weigh this trade-off between an intervention being really expensive, but for a specific, health outcome that we want to achieve, like life saved or cases of cirrhosis averted. But this study was actually very surprising to me in that it was what we call cost saving. So even though there was an upfront cost of the treatment for direct-acting antivirals, which is pretty expensive in the United States, over the course of someone's lifetime, untreated hepatitis C was actually more costly. And as you might guess, it also improved health outcomes to cure hepatitis C early. So it kind of is like a win-win. And that was a really interesting message to come out of the study that I wasn't necessarily expecting, but I think it kind of fit with the intuition that we had going into it, that maybe, that maybe it's worth focusing on upfront mobilization of these resources, allocating them towards children, knowing that it will be like an expensive upfront intervention, but with the understanding that over the lifetime, it'll really improve health outcomes and save money. Really, we wanted to kind of figure out, so aside from the cost savings, we looked at important clinical outcomes. So cirrhosis, decompensated cirrhosis, that's when someone's liver disease becomes so bad that they get so sick they need to go to the hospital. There's a list of things that means. Hepatocellular carcinoma, cancer, and liver-related deaths. And we found that across the board, earlier intervention led to a decrease in those health outcomes, which was really meaningful because these are people who, it's a modeling study, so they're simulated individuals, but they were developing cirrhosis in their late 20s, 30s, and 40s. That's a really young person to have such advanced liver disease. And from what we know about the natural history studies, that is in line with what we see with people who weren't treated early. The reasons why this is really were, I think, it was multifactorial, like many things, but the biggest thing is loss to follow-up. So I alluded to the loss to follow-up issue in terms of kids falling off the Cascade for not getting screened. We didn't really know how many people are making it from if they were diagnosed to being treated. So we estimated really conservatively after talking to pediatricians and experts in the field that 10% of people would be lost to follow-up. I'll say that in the adult populations, it's more like 60%. And so this was really, I was trying to just be like very conservative because it was an assumption that we made. It wasn't based on any empiric data. And what we saw is that it was really that loss to follow-up between either the third year of life or the sixth year of life, or the 12th or 18th year. Those were the different strategies tested. The loss to follow-up was the biggest driver by far of the cost savings that we found. And interestingly, I work with a group that does a lot of modeling and cost effectiveness with adults. And what we're seeing in that population is also that it's this loss to follow-up issue that really is driving a lot of the cost effectiveness of just treating upfront. Also, unsurprisingly, preventing cirrhosis and decompensated cirrhosis just saves a ton of money in terms of hospitalizations, prolonged hospitalizations, and readmissions, which is something that's a huge issue and driver of our very, very high healthcare budget in the United States. And then, I think another thing is that, another thing is just that this study was able to kind of build on studies that have looked at treating kids earlier, but take it through a lens of the entire lifetime and actually be able to show that there is an impact on life expectancy. That goes into the effectiveness, but I think that it's really worth mentioning because this was a new kind of angle to take on pediatric hepatitis C. And it showed that there was significant life years that were added to someone's life if you were to treat them way earlier, at the age of 3. Yeah, so mathematical modeling or simulation modeling, this is an evidence-based methodology that's used really to project long-term outcomes. And that's what I think is so exciting about the methodology is that you can take something that, might happen years and years down the line, and you can take a holistic view of an healthcare intervention that you might do, a clinical decision that you might make. It's tough though, because we don't have a lot of kids with perinatal hepatitis C. If you remember earlier in our conversation talking about the epidemiology, we're just having the increases in people of reproductive age. So that means that we're just having the increases of kids with hepatitis C. So we don't have these cohort studies where we follow people over their entire lifetime in this population. So really, I think that this is where we can use mathematical modeling to try to understand and project. And what we can do with our models is we can calibrate and validate them. In this modeling study, I actually didn't need to calibrate it because when I validated it, which means that I took data that we did have and I saw if our projections lined up, it actually lined up pretty perfectly. So, it is a limitation of modeling though. We're using statistics and we're kind of making inferences and assumptions like the loss to follow up. But I think that what we can take away from it is that maybe we should start thinking more about treating earlier when we have someone in treatment. And really, I think that our clinicians sitting in the chair talking to the patient and their family, maybe think twice about deciding to defer treatment until later because you don't know if that person will come back and actually get treated. And in particular with a kid, different caretakers might have different understanding of the health system. There might be a hepatitis C stigma there. People might move. There's fragmentation of our healthcare records. There's so many things working against these kids. And so I think that, taking the opportunity when you do have a kid who is eligible to treat them up front, I think I'm hoping that this study will kind of plant a seed and start a conversation where people are prioritizing treating earlier. In the future, I'm hoping to look at cost effectiveness of treating during pregnancy. And there have been some studies coming out. There's a trial ongoing, and people are looking at like pharmacokinetics and also like the trial to see kind of if it's safe and effective during pregnancy. And I think that that could be a really exciting way to, way farther upstream than all of these other things that I'm talking about, intervene. And hopefully it's not been proven to prevent transmission, but hopefully it will be. And that could be a very interesting way to leverage that time that someone's spending interacting with the healthcare system during the prenatal period. So I think that that is a really exciting kind of direction to go with the research. And I'm hopeful that we'll get more data about safety and efficacy during pregnancy, because I think that that could not only impact the health outcomes of the child, as we've seen, but also of the pregnant person, kind of helping them improve their health when they're already being seen by doctors and kind of, synergizing those two health issues.